there's two parts to care, obviously. There's the clinical proficiency, and then there's the communication part, how people make decisions. And so the clinical proficiency is really what we teach in the shift. So what I thought is I would talk more about how people make decisions and how to do it in an organized manner to understand people. And the more likely we are to understand where they're coming from, we just care differently. And we plan differently, and people follow through differently because we understand how people think and what makes them tick. So the big shift principle, vitality shift principle we live by and the program is built on is who before what. That is our number one principle in the shift, which is very confusing for procedurally based chiropractors, where it is always what before who, that we will live and die by the procedures that have, by the way, procedures are great. They're the base of the pyramid in your office, but if you live and die by a procedure, what happens is you miss the people in the procedure. So for us, care planning is always who before what. So as important as their case history is, their life history is more important to us, what is going on for them, how their life is not living vividly because of what is going on for them, and what we can do to help them in what is relevant to them. The what rolls out in our procedures on how we do a first visit and how we do a report of findings and how often we do a reevaluation, but the person is key for us. Then it's what before when. So what we mean by this in a care plan is we want to figure out what leverage, where are we going with this? What is important to that person? And what vision do we hold for them long term? Before we go, this is going to take this long. This is what we used to say to people. In order for this to happen, it will take this long. That's my best guess. That's our best clinical guesstimation. But if you've been in practice for any period of time and see any amount of people, I will guarantee you have the experience we had where we're like, well, some people, it didn't take that long. And other people never actually got there. So now you have a conundrum because the when doesn't really seem to always be perfectly aligned to the who. And so that was when we started really playing with what does it mean for somebody to heal? And what does healing look like in our office? And if we really talk about adaptability, which is this ability to bounce back, this ability for the system to be in this state of plasticity where it's like the Matrix, it can take every bullet vividly and like just dodge it. And that's really our goal for people. The key then is how long does that take? That's the wrong question. So it really is important because we used to think that people just want to know how long does it take, how much does it cost, what's it going to take for me to get there. And at the lowest level of care, that is true. At the highest level of a practice that lives in this really internally resourced model called salutogenesis, where we're internally resourcing their strength, those questions can be answered, but not in that linear fashion. And the more linear you are with care planning, the more phased you are with care planning, the more likely people are to stop at the end of those phases. Because that's the way that people think. That's the way they tick. That's what motivates them. And so when do we even get there, or do we ever get there? So we do appreciate that often when we teach these concepts, we're teaching something that's completely opposite to what we've learned. And that was where we were at, because at some level in practice, you know that you're missing a bunch of people. And we just knew, what if we just throw out all the names? Like, let's not call it anything. Let's not call it phases of care. And if somebody comes in weekly, what we say is seminars, even to chiropractors, if you're getting checked weekly, why are you getting checked weekly? And a chiropractor would be like, well, I'm getting checked for subluxation. Okay, so I have been to hundreds of offices around the world, seen probably thousands of patients in and out of offices. I have never heard a patient say they come weekly to get checked for subluxation. And even if they do, and I were to ask them what that means, in their mind, they're still banging bones back in. So that is probably not the pivotal driving force for the public. Here's the chiropractor hat off and the public hat on. So the question is, why would people come frequently? Why do you go frequently? And remember what we said in the last video, just because you go frequently for a certain reason does not mean the next person's going to go for the same reason. Because people have different motivators. They have different intrinsic motivators and they have different extrinsic motivators. We did a little study in our office where we had this gratitude board, and all of our new people listed all these things that maybe some of us can remember way back when we started care. They slept better. They were better parents. Their kids are concentrating better in school. The baby, like all of the sort of intangibles, all of our new people would list. All of our people have been under care. Dawn and I have been in practice almost 22 years. So 15 plus years we've had people under care, which is shocking. Because if you think about how we communicated then, it really does show the power of chiropractic.
Yeah, they still stick around.
They stay under care.
Yeah.
And so these are people who get checked on a very regular basis, who have been under care 15, 18, 20 years. And when I ask them to do a gratitude card, they're like, God, I don't even really know why I come. I just know it's just better. I'm like, perfect. I don't care. I just care that they show up. So I think we have to also not be too dedicated to having our people just say the right thing. As long as somebody comes in the door, your job is done. So we're not saying don't communicate well and don't educate. I'm just saying sometimes not everybody's going to have the language. They just know it's the right thing, which is really cool. So what we decided to do is we decided to say that all of our care plans were a life cycle. And this life cycle was based on people's motivation and their ability to sustainably change. Every care plan has a life cycle. And that life cycle, for most of us, our end goal that is a person's life cycle. Obviously, we would love people to be under care from birth to death. Not everybody's going to be under care from birth to death. Everybody will have a life cycle to their own care plan in their practice. It has a frequency life cycle. So this is what we used to call phases of care. So perhaps in the beginning, somebody than they do later on. And you determine that clinically based on your objective findings. When somebody can graduate their care, if they can graduate their care, and why. So that's a frequency life cycle. There's a clinical outcome life cycle. There are certain things that I believe you are looking for as indicators with your clinical proficiency that have a life cycle. When those are met, you may have new life cycles with clinical outcomes. And again, that's all depending on what your intention is in your practice. So it has a monetary life cycle as well, meaning a lot of people, this is why care planning gets mixed up with financial planning, because we consider them the same thing, but they're not. Money supports a care plan, particularly for most of us that are around the world that don't take insurance. In the United States, it's called a cash practice. For the rest of us in the world who never really jumped on the insurance bandwagon, it's just the way we've always practiced. But people have to pay for your care. And there are ways and mechanisms that many of us can do under our regulations where we will reward people for that for some way, in the sense we might be giving discounts or making it more available for them to pay monthly if you can do that, or whatever it is, packages. We don't cover those details because there's too many countries represented for us to really say what the rules are. You need to know your own rules as far as what financial life cycles you would have in your care plan. So in order for a care plan to be effective, we must understand people as much as we understand chiropractic. So I think if I were to state the one thing, if somebody were to look back on my life that I provided to chiropractors and chiropractic assistants, is I want people to obviously continue to deepen their knowledge of chiropractic, but I want them to do it as much as they deepen their knowledge about people. And I believe we spend more time learning about things that are not relevant to people and how people tick and how they think and how they behave. And I think if we could marry those two together, we'd be much more effective in chiropractic.